that should you really not solve this matter at a very political level, it might actually cause a worse fracture than ever.
And now, Dr. Sabaki, we also know that now the Political Funding Act has since come into effect today. That is, when I last spoke to the IEC in the province, they expressed optimism to say that the act will allow them an opportunity to maximize their role of overseeing electoral fairness. Do you share their sentiments with regards to this Political Party Funding Act, Dr. Sabaki?
I think the issues forthcoming, I really share their sentiments, particularly as it's going to really unlock the issue of accountability, which is really a running theme that is ushered by our own democracy. Because if we talk about accountability, you can't start accountability at the level of government. We must also talk about accountability and transparency at the level of political parties, so that they are able to disclose. Because one of the key challenges at the current moment is the insinuation that there are those who serve the interest of certain hidden funders, which really upset campaign and people's belief in terms of their wishes of what they want their government to look like voting for them. So I think this really is an opportune moment to really complete down the issue of accountability to political parties themselves.
All right, political analyst Dr. Bennett Sabaki, thank you for talking to me tonight.
Thank you very much.
Thank you. We discuss female health matters coming up next.
Conversations, Mondays to Thursdays, 6:30 p.m. to 8:30 p.m. with Rebecca Pala.
The time is 24 minutes to 8. This is Conversations on Energy FM 102.1 and Choice FM 101.1. I bet everyone is ready to consult with our resident gynecologist, Dr. Maluleke, who joins me in studio now for an hour of female health talk. As always, no question is off the table, and that means any question that you have which has to do with female health can be sent our way. This is how you can get in touch with us. Our WhatsApp text line is 079 295 1212, 079 295 1212, or you can send us a voice note to 060 771 5107, 060 771 5107. Alternatively, you can give us a call.
Have your say. Call us now on
015-151-1058. That's the number to dial. Dr. Maluleke, good evening. Welcome back.
Evening, Rebecca. Good evening to our listeners.
Are you well, doctor?
Very well, and how are you?
I'm well, thank you. You know how we are in the weekend of Easter?
Yeah.
It reminds me of how far along we actually come with you. Because this is is it the third time, or do you know? Have you been counting?
Yeah, it's the 30th year now.
It is,
yeah. It's been a while.
Perhaps we should reflect briefly before we get into our discussions how the experience has been for you. I mean, we always hear from people needing your help, but we hardly ever check up with you to say, Doctor, how are you? Are you still happy with everything in terms of our engagement?
Well, I should tell you a secret tonight.
All right.
And the secret is that I've actually been a lecturer.
Okay.
I lectured to medical students, and I found that to be something that was very fulfilling. Now that I'm not able to do it, this program actually substitutes for that. I was lecturing when I was still attached to the university, and I find that imparting knowledge is also a form of learning.
Sure.
If you discuss issues with people, you also learn in the process. And I think I've learned quite a lot, because there are some things that you would hear for the first time on the show, and you go and check them out, and you find that you've been empowered that way. And from when we started, initially we used to have a topic, and then we would expect people to stick to the topic. But then I realized that people had lots of other problems, and perhaps we were restricting them when we had a topic of the day. And then we made a decision that let's open it up, and people could ask about anything and everything gynecological. And I think we are doing quite well.
Okay, let's jump straight into the questions then, Doctor. Good evening. I want to know what may be the cause of itchy nipples.
Itching nipples could be just a hormonal thing, because in some people this happens cyclically, part of the premenstrual syndrome, PMS. But sometimes it could be an allergic reaction, and sometimes it could just be because of anything that you may be in contact with that may lead to you developing that. Could be a dermatological problem. But largely, if it is something that comes on a regular cyclical pattern, then it is part of the hormonal milieu in your body.
Okay.
Yeah.
Good evening, Rebecca and the good doctor over there. I would like to know if there are medical ways that can be explored to assist if a woman takes time to reach sexual orgasm.
Medical ways. Well, I suppose they could be, but in most instances, you will find that there is nothing wrong medically with the person. It's just the way their bodies are engineered. Some people are anorgasmic. By that we mean that they enjoy the sexual act, but they actually do not reach climax. And some people would have multiple orgasms, and because their bodies readily respond to this. But in some people, you will find that it is a psychological issue, which may stem from childhood. The way we were brought up. The issues of sex are not discussed, and sex is dirty, and so on. People don't even talk about it, and therefore some people will be restrained in that respect, and they may find that this kind of thing will affect their sexual enjoyment as a result of all these issues that may have started in childhood.
I'm actually reminded of something that was once said on a television show I was watching by a sexologist who was saying a lot of people battle to enjoy sex because of what they've been told about it.
Yes.
And so when they are in the act, they keep thinking of what they've been told by their parents, by elders in their lives. And
it's dirty, it's dangerous, and you need to be careful. And all the time, some people do it with fear. And when there is fear, obviously there is not going to be any enjoyment.
So we need to do better as a society.
Well, fortunately, I think the younger generation, with all this information available to them, information has helped them. The older generation, they are the ones that probably suffer from this more. But nowadays, information is out there. People read and people talk, and perhaps programs such as this one will go a long way also in educating people
and I'm sure
about these things.
I'm sure even the next question certainly will just normalize sexual acts. It reads as follows: Hi doctor, is it normal if I like to have sex mostly every time with my partner?
Absolutely.
Are there ever instances where a higher sex drive is actually indicative of something problematic, doctor?
Well, yes, if there is a concept called sex addiction, all right? An addiction of anything would be regarded as a problem, because addiction makes it impossible for you to function. You cannot function unless you get your fix. So sex would be the same thing. If the sex drive is so high such that it occupies your mind all of the time, obviously you're not going to be able to have a normal social interactions with people, because sex would be the only thing in your mind. You won't be able to be productive at work, and you will become irritable because you can't get your fix, and you become an unpleasant person. Sometimes you may even engage in criminal sexual activity such as rape, because you would want to have it and you want to have it now. So in that instance, it becomes a problem. But there are couples that have healthy sexual activity and they would have sex. Some of them would say they have it daily, unless there is an illness or maybe menstruation or anything. But otherwise, they have a healthy sex life and they have it as much as they can.
Okay.
Without necessarily causing any problem for anyone.
Good evening. I have a problem of seeing my periods twice a month. What could be the problem?
We need to understand what that means, because we have said in numerous occasions that people might think the menstruation is twice. But if you have a shorter cycle, it is possible that you can menstruate beginning of the month, and before that same month ends, your period will be back. That does not necessarily mean that you're menstruating twice. It just means that you've got a short cycle, and that for you is normal.
Okay. I'm in conversation with our resident gynecologist, Dr. Maluleke. We're taking all of your gynecology-related questions. Send them through to our WhatsApp text line 079-295-1212, 079-295-1212, or you can send us a voice note instead to 060-7715-107, 060-7715-107, or you can give us a call as we continue with this discussion after the break.
Have your say. Call us now on 015-151-1058.
Hey, Chomi, I've just received my varsity admission letter and I need a place to stay in
What's the
Pretoria.
plan, Doctor?
Chomi, CBD residency has a variety of student luxury accommodation all over Pretoria. Let's visit their website now at
Proposal about Easter.
cbdresidency.co.za. Wow, Chomi,
What's going
they
to
are
happen at
affordable
your church?
indeed. Let's
No,
call
my
them.
church,
012
the other announcement came late for us because we had already decided we're not going to have the normal Easter activities. We will just have a normal service, which is similar to our Sunday service. We'll be in church at 9, and probably within 1.5 hours we'll be done. But normally we would have a full day service at Easter, where we do the 7 days of the cross, and would even have lunch there. But this year we would not be having any of that.
That's not nice. Because I legit thought that maybe today you'd say, hey.
No. Even if there was going to be a service, I would interrupt that and come to the studio, and then go back afterwards.
COVID is just messing up so many things. We're talking to the chairperson of the Council of Churches.
Yeah.
Just around the traditions of Easter in the church and how they can be changed. You could hear the devastation in his voice. It's the new norm, I guess, but
Yeah.
it's very difficult to work around.
Birthdays, weddings, and accommodation. With Haven Springs, you can ride, swim, and enjoy our free Wi-Fi. Haven Springs, Utilivu, Safi, rest, rejuvenate, release.
You haven't gone live since the first attempt, have you?
I have. I am live now.
Are you?
Yes,
Oh, okay.
I am live.
I didn't know.
You are asking.
Are they interacting?
Yes, they want to know the number at which we can send a message.
Did you give them?
Unfortunately, my screen.
The radio screen, they could see it behind you.
Conversations
The
with Rebecca
screen is showing my number.
Have your say. Call us
Really?
now on 015-151-1058.
The time is 12 minutes to 8. This is Conversations on Energy FM 102.1 and Choice FM 101.1. We are in the middle of our open line of female health. with our resident gynecologist, Dr. Maluleke. This is how you can get in touch with us and ask all of your gynecology-related questions. Our WhatsApp text line, that's where you send a WhatsApp text and not a voice note. That WhatsApp text line is 079-295-1212, 079-295-1212. Or you can send a voice note instead. The number to send your voice note to is 060-771-5107, 060-771-5107. Alternatively, you can give us a call. The number to dial is 015-151-1058, 015-151-1058. A question here on WhatsApp. It's becoming a famous question, I must say, Doctor, and I'm sure you will agree. I'm going to just read it, and I'm certain you're going to agree. Good evening, Dr. and Rebecca. Is it normal to steam the vagina? Please help.
Is it normal? Vaginal steaming is discouraged by doctors and health professionals in general. I suppose there are people who sell the idea to the public, and they tell them the advantages thereof. However, the claims that were made with regards to vaginal steaming, some of them are preposterous, such as vaginal steaming curing infertility or curing cysts and fibroids. Those are claims that are very, very far-fetched, because there's no way that the steam can go in and then destroy a fibroid. It does not make sense, both anatomically and physiologically. It makes no sense. However, there does seem to be some degree of improvement for those who suffer period pains. But this you can explain in a similar way, similar to what happens when you use hot water bottles. This is what we said. But all the other things are not supported by evidence. Nowadays, we believe in what we call evidence-based medicine. We need evidence to support that that which you are doing is useful. And there is no evidence now to support that vaginal steaming actually does what they claim it is doing. Right.
And yet it's gaining so much traction, Doctor.
Well, remember that some people are in business. And when you are in business, it's the same thing, Rebecca, as people... You can see flyers everywhere. There is a concept of enlargement of the penis, you know. There are men who apparently would like to have their penises enlarged. And these people will tell you that they can do it for you. I'm here to see a man who has actually gone for that treatment and his penis is bigger, right? But because there is this promise that is being made, there are desperate people who will go there. And I can go further. Even with COVID, there are people who have claimed that certain concoctions can cure COVID. HIV is also an issue in a similar kind of situation where people claim they've got a cure for HIV. And there are people who will actually buy into that and they'll go and seek this because they're desperate. So vaginal steaming, it's a fad that is there, but no medical advantage.
No.
And in fact, it could be dangerous because you disturb the delicate balance in the vagina. There are cases of burns. Remember that the genitalia is a very sensitive area, so you can easily burn the genital area from the steam, which is very, very hot. So we don't encourage it.
Have you perhaps heard even from colleagues that they've had to deal with cases of people who had used steaming and it went completely wrong, as you're warning now? Yeah,
there are papers that have actually reported things such as those, but I have not met colleagues that have actually encountered situations like that. But there are publications that suggest that this could be dangerous, actually.
Okay. Let's talk to Anonymous joining us on the line. Anonymous, good evening. Welcome.
We are well and you.
Well, thank you, Anonymous. How are you? Sure. Hmm.
Is that the only thing they told you? Okay. All right.
Will you listen on
Your
the radio?
child, how was your child delivered? It was a cesarean section. Okay, thank you.
You will listen on the radio, Anonymous. Thank you, Doctor.
Yes. The listener is talking about the position of the cervix in the vagina. The cervix can assume three positions in the vagina. It could either be central, anteriorly, it could be central, it could be posteriorly. And this is also a reflection of the position of the womb in the pelvis. When you have a uterus that is facing or is more towards the back or into the hollow of the sacrum, the cervix will be upwards. This is known as a retroverted uterus. And sometimes both the uterus and the cervix are along the axis of the spine, and that would be an axial position or central position. And sometimes the cervix will be facing more towards the back, meaning that the uterus itself is more towards the anterior abdominal wall, what we call anteversion. Now, the majority of women have an anteverted uterus with the cervix that is facing towards the back. This position is the desirable position because if the cervix is towards the back, that is where semen is deposited, and it is easier for the semen to enter the cervix and then pregnancy takes place. If, on the other hand, the cervix is pointing anteriorly, it might be difficult for her to fall pregnant because the semen will still be at the back, but the cervix will be away from where the semen is deposited. So, in that instance, there might be an operation that is done to put the uterus back into position, what we call ventral suspension. But what would have caused the uterus to be retroverted and therefore the cervix facing anteriorly? In about 15% or 20% of women, this is natural for them. They were born that way. In the rest of the women, there is something in the pelvis that is pulling the uterus backwards. And this could be, that's why I asked her how the baby was born. If she had a cesarean section, it is possible that during the healing process, there were adhesions that formed that pulled the uterus backwards, and that will lead to the position as described on the show now. But infections can also do the same. Pelvic infections can lead to the uterus being pulled backwards, and the cervix will go upwards. And listening to her, Rebecca, there clearly is a problem of infertility here because she's got a 16-year-old, all right? Well, she's 35. It means she conceived around 17. And I assume that the man she's with is not the father of the child she's having. So these are factors that we must take into consideration. That she is infertile, she has a retroverted uterus, and therefore we need to know the state of the tubes. Because clearly they had been together now and there is no child coming. But we also need to know if the husband has fathered children himself. You may find that there is nothing wrong with the lady. The problem could be with the man she's with. So the couple needs to go. But she says she's been to a gynecologist.
Yes.
I would like to believe that with her condition and her situation, the gynecologist must have gone further to investigate and try and unravel this mystery of why the cervix is the way it is and why she's not falling pregnant. The two could be linked.
Okay.
Yeah.
Who tests male infertility? Is it done by general practitioners?
General practitioners can refer the patient, the man, to the lab to do a semen analysis. We also do that, but the correct specialist for male problems is a urologist.
Mm-hmm.
We have several now in Polokwane. We used to have 2, but now the number is increasing. So there are urologists that can sort that out.
Okay. Good evening, doctor. I'm in my late 40s and I spent months without my periods. They come after 2 to 3 months. I haven't seen them since last year, September. And I've been experiencing hot flashes. I sweat every day during the day and night. Have I reached menopause yet? Will the periods come back?
This is a classic case of the climacterium. The climacterium is the period around the menopause. And the lady is indeed experiencing menopause. And this is typically how it happens. The period will go away, and then it comes. And when it comes, it may be prolonged. And there are hot flashes. She's sweating. She's got palpitations. She has insomnia. She's got listlessness and mood swings. These are difficult people to be around. And sometimes they do not have a desire for intercourse. Or when they have intercourse, it is painful because the vaginal lining is thinning out because of lack of estrogen. The ovary is no longer producing eggs, and therefore you don't have the female hormone that nourishes the lining of the vagina. So, yes, she is experiencing menopause. This might go on for a while, but ultimately she will stop and never see her periods again. Once they have stopped for a period of 6 months, we would say this is menopause. Bleeding after that is no longer regarded as menstruation. It will be regarded as post-menopausal bleeding. And post-menopausal bleeding is a serious condition. It might indicate that there is a serious underlying problem. Therefore, you don't relax and say, my periods are back. If you have been without menses for that kind of period, you need to go and be examined to exclude serious conditions, such as cancer.
Just to make sure I heard you well, if they don't come for 6 months, and then they come after that, then
it's no longer menstruation.
Okay.
It's post-menopause. It's now a disease.
Okay.
Right.
Our WhatsApp text line is 079-295-1212, 079-295-1212. And then our voice note line is 060-771-5107, 060-771-5107. Alternatively, you can give us a call. The number to dial is 015-151-1058, 015-151-1058. Good evening, Dr. Rebecca. My partner is 33 years of age. She has been on her period since the 15th to date. She normally sees them for 3 days, but this time it's different. According to her, she feels the blood on her abdomen and finds blood when wiping.
Yeah, well, she's been bleeding for 2 weeks instead of the 3 days that she's used to. So this definitely is a problem. It could be a pregnancy-related problem. She could have conceived and now maybe she's having a threatened miscarriage. She could be having an ectopic pregnancy. But it could also be just an abnormal ovarian function, wherein ovulation may not have taken place the correct way. The only way of knowing, of course, is for her to go and get examined. Among other things, a pap smear needs to be done because you could be having a local lesion on the cervix that is explaining the kind of problem she's experiencing. So it is necessary for them to go and consult.
This concept of a threatened miscarriage.
Yeah.
Talk to us a bit about it.
That's when you're pregnant and you start bleeding. Usually this bleeding is painless and there are no clots. When we examine you, we will find that the pregnancy is still intact, the heartbeat is there, and the cervix is closed, but you are bleeding. There is a threat to that pregnancy. With treatment, some people will then stop bleeding and the pregnancy can continue. In some people, even with treatment, the condition may still continue and you develop the further steps of miscarriage, such as the next step after that would be what we call inevitable miscarriage or inevitable abortion, wherein now the bleeding is painful and there are clots, and often the cervix is open. In this group of women, no amount of intervention will reverse the process. And when it goes further, you now have what we call either a complete miscarriage or incomplete miscarriage, where the complete miscarriage means everything has come out. You do not need to go to theater to be cleaned. If it's incomplete, it means part of the conceptus is still in the uterus, and therefore you need to go and be cleaned, what we call an evacuation or womb scrubbing. That will be the whole spectrum of a miscarriage. Okay. A missed miscarriage, there's a patient I saw today, referred to me by a general practitioner. This is a patient I delivered in 2019, delivered her baby in 2019. No, in fact, she delivered a baby last year. She had her first baby at around 36, and now she's trying again to have another baby. She's 11 weeks pregnant. No, in fact, she's 14 weeks pregnant. And yesterday she went and saw a general practitioner who picked the fact that the heartbeat was not there anymore. She has no pain, she's not bleeding. This is known as a missed miscarriage or a missed abortion, wherein you are still pregnant, the baby is not alive, you are not bleeding, you don't have any pain. That is known as a missed abortion.
Okay.
Right.
Would you say, doctor, that there's a lot of women who have experienced a threatened you said a threatened
miscarriage.
A threatened miscarriage, and perhaps they missed it?
Yeah, some of them will have it, and not, especially when they're not aware that they're pregnant. They might think it's a menstruation, only to find that this is a pregnancy, and that pregnancy is in danger. And one of the most important things in terms of treating this kind of problem would be to rest. Okay. Bed rest is a very important part of the treatment, and also to stop having intercourse, because if you continue having sex when you are pregnant and you are threatening to have a miscarriage, sex can actually make things worse. So it's important, therefore, to diagnose the pregnancy first, and then to advise the woman on what to do and what not to do.
Okay, let's talk to Rose. Rose joins us on the line. Good evening, Rose. We're well, thank you, Rose. How are you?
Hello, Rose. How are you? I'm very well, thank you. Right. It's not very common to feel a growth of the tube and that of the ovary. When you feel it, it will be very, very big. And this would have presented way before yesterday. So I do not believe that what you are feeling is on the tube or the ovary, because those are structures that are very far from the abdominal wall. And it's not very easy for you to feel that. So it could even be just an abdominal wall swelling and not necessarily be on the tube and or the ovary. So it is still important for you to go and consult your general practitioner. They will examine and they will do an ultrasound, because an ultrasound would be the quickest way of confirming the location and the nature of the growth you're talking about. Yeah, Bob.
Are you sorted, Rose? Thank you very much. Okay, let's take another call. All right. Good evening. Welcome to Conversations Anonymous.
We are very well, and how are you? Good. Why are you on anonymous? You are having issues you don't want. You are anonymous. I'm just interested to know why. You've got secrets here, or people will know who you are. You don't want to have people knowing your problems. Okay, no, that's fine.
Anonymous, just quickly switch off your radio so we can hear you properly. Is it off? Okay, talk to us.
What? I do not hear what you are saying. BTC. Can you say that in full? What is BTC? Yes, you did a cesarean. So what is BTC? Oh, both tubes closed. You see, I told you, Rebecca, we learn every day.
Yeah.
Both tubes closed. Yes. So, okay. You mean intentionally or unintentionally? Both. Okay. All right.
Anonymous, will you listen on the radio?
Basically, we are being asked about the efficacy of sterilization. How effective is sterilization? And I think last week we touched on it as well.
We did.
We need to make listeners aware that sterilization can fail, right? And it does fail. And we even said it does not matter who did the sterilization. Even the most experienced surgeon, such as myself, I regard myself as an experienced surgeon because I've been doing this for almost 30 years now. And anybody who does something for 30 years is fairly experienced.
Yeah.
Yes, I do have patients who fall pregnant even after I have sterilized them. So there is a possibility of falling pregnant, but that is unintentional. But if you want to conceive intentionally after sterilization, there are a few things you may consider. One, you will have to go and have the reversal of the procedure, right? There is what we call reversal of sterilization, which might assist in you falling pregnant. The reversal, however, the success thereof depends on, one, what procedure was done at the time of sterilization. If the tube was tied and cut, the chances of success are not very good. If the tubes were clamped, what we call laparoscopic sterilization, in other words, the whole tube is still there, but we just blocked it. We just simply go and remove the clamp and then we re-anastomose, or we join the tubes together. Then the chances of falling pregnant will be good. That is the first issue. The second issue would be the age at which the reversal is done. Because as you get older, you become less fertile. The ovary is not that of a young woman anymore. Therefore, it's not readily responsive to hormonal stimulation. Thirdly, success will depend on the surgeon who's doing the procedure. Like I said earlier, when you are experienced and you do these things repeatedly, like they say in English, practice makes perfect. So if you do something repeatedly, you're likely to be good in that particular procedure. So those are the issues we consider. And the other option you have would be to straight away go and have in vitro fertilization, which is a procedure wherein you will be given medication to stimulate the development of eggs, and these eggs are harvested and they get mixed with the sperm of your partner in the laboratory. Fertilization takes place in vitro. In vitro means in the test tube. In vivo means it takes place in the body. So once fertilization has taken place, these eggs are then transferred back into the uterus and you are pregnant. Perhaps if we were to put this in perspective, comparing surgery and IVF, in vitro fertilization, the one who does the latter has a much better chance of success than the one who goes for an operation.
Okay, let's go back to the WhatsApp text messages. Good evening, Rebecca and Dr. Baluleke. I would like to ask if there can be complications when a condom bursts and a part is left inside of a person, and later on the piece comes out after some days, is there a cause for concern to see a doctor when this plastic has already come out?
No, there is no problem actually. If you have a best condom and there is a piece, you can even remove it yourself. You know, I remember a couple that I saw many years ago when I was a medical officer at Mankweng Hospital. University students from the University of the North. Mm-hmm. They had intercourse during the day and the condom was retained. And they came and they were terrified because they thought this condom must have found its way maybe to the heart or something. And they were very much surprised when I simply put the finger in and came out with a condom. Because the anatomy is such that that condom cannot go anywhere. It will always be in the vagina. When it happens, you simply put your finger in and you take it out. And there is no danger. Of course, if it stays there longer, being a foreign body, it will predispose you to infections. So just like I saw a patient not so long, I think about 2 years ago, she had a tampon and she forgot it there. And she was just surprised to have a very bad smelling discharge. And she came, and when I examined, here is the tampon, and I took it out. And she says, how could this be? How could I even forget this? But a foreign body in the vagina will do that.
Do they always have to be taken out, or do they release themselves? Like in this case where this person says the plastic then, or the remaining part then came out. Do they come out by themselves, or how
ultimately it will come out, okay. But we don't know when. The longer it stays there, the more the chances of you getting infected.
Okay. Doctor, I gave birth naturally around February. My stitches have healed, but I still experience spotting. Is it normal?
In February, she gave birth.
Naturally, yes.
Yes, and now it is April. She's still spotting. Mm-hmm. Well, we would like to know what conception she's on. Sometimes they get given the injection before they go home, and that would be the reason. But if she has not been given any conceptive injection, we would expect everything to have settled within 6 weeks, and 6 weeks has long passed from February to now. She should have gone beyond the 6 weeks, and therefore the spotting could indicate that there are other problems there.
Okay. Hi, doctor. I would love to stay anonymous. I had a miscarriage on the 19th of February, so my fiancé has been experiencing pain in his penis, and the doctor checked me out after the miscarriage but did not see the cause of the miscarriage. And before the miscarriage, I had a smelly like discharge. Can this mean that I'll forever have a miscarriage? Please balance me.
No, it does not mean that. And in fact, also the fact that she had a miscarriage might have no bearing on the pain that the partner is experiencing. Assuming, of course, that after the miscarriage, she had the womb cleaned. And if that was done, then that aspect has been dealt with. So if she had it on the 19th of February, that makes her 6 weeks. Tomorrow it will be exactly 6 weeks. I know this because I also got operated on the 19th of February. So my 6th week is tomorrow. So at 6 weeks, everything is settled. We expect everything to have gone back to normal. But if she had a discharge prior to the miscarriage, it is possible that she could have had an infection, which is why she had a miscarriage, and the infection could have been sexually transmitted. But for her now, if she was evacuated, I think that has been dealt with. But the man needs to be examined because he could still be having the infection.
Okay, we are in the middle of our open line of female health talk with our resident gynecologist, Dr. Maluleke. We are taking all of your gynecology-related questions. This is how you can get in touch with us. Our WhatsApp text line is 079-295-1212, 079-295-1212. Our voice note line is 060-771-5107, 060-771-5107, or you can give us a call. The number to dial is 015-151-1058, 015-151-1058. We'll continue with this conversation after the break.
Call us now on 015-151-1058.
At Boston City Campus, You'll earn qualifications which have UK accreditation and Candidate United States accreditation. Apply now. boston.co.za. Serious about education. Serious about you.
Does your home or office space need cleaning or disinfecting to guard against the coronavirus? Are you tired of having to wake up to an unkempt garden every morning? Well then, let Mukiditi Cleaning and Projects come to your rescue. Mukiditi Cleaning and Projects offer reliable, flexible, and professional cleaning and gardening services. Call 079-451-7967. Mukiditi Cleaning and Projects, the best in cleaning.
Very well.
The most exciting part
so
of a wedding for a bride is
people still want to ask you male health questions. Like I don't know, because we literally are saying, guys, hi, gynecology related questions.
You see, this is why we decided on the open line.
Yeah.
Because often when we have a topic, people don't stick to it.
Hi. It's such as the nature of show business.
It's all about the dress.
Does your school, church, company, society need tailored clothing, uniforms, printed caps, t-shirts, and beanies in Polokwane? Well, Moti Branding is your go-to shop. Visit Moti Branding at Hostel Block H in Zone 6, Sesheo, or call 015-223-0675. We supply all over Limpopo. Moti Branding, we do it in style.
Don't let the crazy weekday morning rush stop your family from getting a quick and tasty family breakfast. Nyala Instant Breakfast Porridge is the delicious, quick and easy way to start every day. Nyala Instant Breakfast Porridge is available in 5 yummy flavors that mums choose and kids love. And you can make it hot or cold with water or milk. Plus, this tasty breakfast is packed with the goodness of 12 vitamins plus iron and zinc. Stand a chance to win a share of 100,000 Rand towards your kids' education when you buy any 2 tasty Nyala Instant Breakfast Porridge packs. Buy in store now, and don't forget to follow Nyala South Africa on Facebook for details. Nyala, the royal taste.
Conversations, Mondays to Thursdays, 6:30 to 8:30 p.m.
The time is 20 minutes past 8. This is Conversations on Energy FM 102.1 and Choice FM 101.1. I'm in conversation with our resident gynecologist, Dr. Maluleke, and we're taking all of your gynecology-related questions. This is how you can get in touch with us. Our WhatsApp text line is 079-295-1212, 079-295-1212. Our voice note line is 060-771-5107, 060-771-5107. And if you would like to give us a call, the number to dial is 015-151-1058, 015-151-1058.
Have your say. Call us now on 015-151-1058.
All right, let's go back to the questions on WhatsApp. Good evening. I'm 8 weeks pregnant and I'm having constant urination that is sometimes even short. Can that be UTI, and what advice do you have regarding that?
Right. Constant urination is one of the early symptoms or one of the symptoms of early pregnancy. When the uterus is still confined to the pelvis, it tends to put pressure on the bladder. Every time there is a bit of urine entering, you have to go and empty the bladder. And that is not a disease. Infection, on the other hand, would be that symptom, but it will be accompanied by burning. It's painful when you pass urine. The one that we described earlier would often not be accompanied by pain, and there would be no burning. It is just because of the uterus that is expanding. It will get better once the uterus becomes an abdominal organ. At the moment, at 8 weeks, it is a pelvic organ. And later on in pregnancy, when the baby's head tends to engage, when the head is falling into the pelvis, this will come back.
Okay.
Yep.
Let's talk to Virginia on the line. Virginia, good evening. Welcome to Conversations. Hi, Virginia. We're well. How are you? Talk to us.
Yingisile. Unamalembe mangani wena? Sihlangi singani? Xin'we xi beburiwe njhani? Right. Nuna wa wena loyi ku nga na yena sweswi yena tatana wa xihlangi? U na vana yena? Okay. Mi tshama swin'we full time? And mi kotlana kangani a vikini? Ku hava pain loko mi kotlana? All right. Okay.
Will you listen on the radio, Virginia?
Yes, sir.
Okay. Virginia, will you listen on the radio for the doctor's response? No problem. Doctor, before we answer Virginia's question, let's talk to Anonymous. Anonymous, good evening. We're well, Anonymous. How are you? Sure, talk to us. Anonymous, we can't hear you very, very well. As you get into the details about the skin condition, it becomes very difficult to hear you. Try moving around a bit so we're able to hear you. Much better, yes. Go ahead. You can ask Gaspedi. It's not a problem. I just wanted you to move so we can hear you clearly. Okay. Is it clear, doctor?
Yeah, no, it's clear.
Okay, Anonymous, you listen on the radio for the doctor's response. Thanks.
Yes, let's start with the initial question
by Virginia. Yes.
By Virginia. Virginia has a child and she's not able to have another one now. She's not on conception, she's married. The husband is not the father of the child, but he has children and they have intercourse at least 2 to 3 times in a week. She's got a bit of low abdominal pain and this has been going on for a while. And she wants to know what is going on. Just like we answered one of the callers earlier, there is a clear problem here of infertility, secondary infertility, which by definition means if a couple has unprotected intercourse regular and they do not have a baby after 12 months, that is a case of infertility. This could be a problem of the male, it could be a problem of the female. And as far as that is concerned, there is none who's better than the other. Because in 40% of cases, we find that the problem is with the female. In 40% of cases, the problem is with the male. In the remaining 20%, it could be both. Therefore, it becomes a couple problem, and the investigations need to be done in both. I would urge them to go and see their doctor, who would do the necessary investigations, and then we will know what the problem is with regards to infertility and also why she's having the kind of pain that she's suffering from.
Okay.
Right.
And then the question of Sekhalaka.
Sekhalaka. Sekhalaka, Rebecca, it's a term that is used to describe all sorts of rash. Mm-hmm. You know, some people say Sekhalaka skamogare, others have got Sekhalaka on their faces, others, you know, when they feel itchiness in the vulva, they say Sekhalaka. Therefore, because it is a condition that might be describing lots of medical problems, it is difficult for me to say what is Sekhalaka, because they use it for a lot of things. There's something I was thinking about, but it just escaped my mind. But let's go back to what he described as the problem with the child. Mm-hmm. The child has got eczema. This is a clear dermatological problem that affects many children in childhood, eczema. They get a scaly skin which is dry and flaky, and it is very itchy. The child will be scratching himself or herself on a constant basis. So, most of these children will have it around the age that is described, and when they grow, they outgrow it. But it will need treatment. It is not something that the mother passes to the child. No? It does not mean that the next child will develop the same problem, because then it means this problem is within the mother and the mother is transmitting it to the unborn child. No, that is not the case with eczema. And it might not affect the next child or the subsequent children that she's going to have. Therefore, she need not fear to fall pregnant. She can have children who will not develop this.
Okay.
Yeah.
Doctor, that is our time. Kindly share your contact details with us.
Yes, we are at 72A Compensati Street in Polokwane, 015-295-9407.
Okay, Doctor, enjoy your Easter weekend. We will reconvene next week.
Thank you. Enjoy your Easter too. Drive carefully.
Thank you very much, Doctor. That's our time on Conversations. Coming up next is Night Flight with Matumo Manaka. A big thank you goes to you for listening and interacting with us, and to the show's producer for making sure that we sound as well as we do on a daily basis, and he is Mr. Emmanuel Gwenda. We meet again on Monday with more Conversations. Good night.
All day, every day. We keep the hot songs coming all day long. On Energy FM and Choice FM. Matumo Manaka on the Night Flight.
Yeah. Oh, another crate.
Like a